Respiratory system in children. Organs of respiratory system in children, like in adults, they are nose, pharynx, larynx, trachea, bronchial tree, and lungs. Basic functions of the respiratory system, also the same with adults: sense of the smell, protective function, voice formation, oxygen supply to the body, release of carbon dioxide from the body, air distribution for gas exchange, elimination of toxic substances that have entered the blood, metabolism of some substances, and blood depot. Embryogenesis of the lungs consists of 4 stages. First stage, glandular, which lasts from 4th to 16th weeks of intrauterine development. Next, recanalization, lasts from the 16th to 24th week of intrauterine development. Alveolar, lasts from 24 to 40 weeks of intrauterine development, and postnatal lasts from the moment of birth up to 12 years old. All these stages you can see on this picture. If any factor will affect lungs during formation of the lungs, we can receive various abnormalities of the lungs. For example, this X-ray with agenesis of the right lungs. You can see all organs of the mediastinum dislocated to the right side. Purulent cyst of the right lung. You can see large cyst on the right side with fluid, with level of fluid. Next, X-ray, congenital lobular emphysema. You can see emphysema on the right side, organs of mediastinum dislocated to the left side. Next picture, congenital cyst of the right lung. You can see on the right side, cyst without fluid, X-ray picture, and computer tomography. Next, Carter-Jenner syndrome. Carter-Jenner syndrome, genetic disease, is characterized by inverse location of internal organs, chronic bronchitis, and chronic sinusitis. On this X-ray, you can see dextrocardia and signs of the chronic bronchitis. Hypoplasia of the left lung. Next picture, you can see hypoplasia, small left lung, bronchoscopy. Anatomical and physiological features of the respiratory system in children. Sinuses. Additional sinuses of the nose in children are not sufficiently developed. Maxillary sinuses develop at 7 years old, ethmoid at 12 years, sphenoidal sinus at 15 years, and frontal sinuses develop at 20 years old. Due to underdevelopment of the sinuses, we have rare cases of sinusitis in children. Nasal cavity. Features: narrow nasal passages, lower nasal passage is absent in infants. The completion of formation occurs at 4 years old. Nasal mucosa is covered with a ciliary epithelium. It is thin, delicate, has a rich network of blood vessels. Submucosal layer contains little cavernous tissue. This tissue increasing in the mass absorbed at 8-9 years old. So we have rare cases of nasal bleeding in babies. Pharynx. In young children, relatively short and narrow, auditory tube which connects the nasal part of pharynx with a middle ear cavity, short, wide, and straight. Clinical significance of this feature leads to easy introduction of infection from the nasal part of the pharynx to the middle ear cavity and frequent cases of otitis in children. On this picture, you can see pharynx in children. Lymphoid tissue of pharynx is not developed. It develops at 4-10 years old. So there are practically no angina in children during first year of life. In children, most frequently observe hypertrophy of the pharyngeal tonsil. We call it adenoids. Adenoids, due to hypertrophy of pharyngeal tonsil, adenoid type of face forms. Broad nose, nasal tone of voice, constantly open mouth, snoring during sleep. On this picture, you can see this adenoid type of the face and hypertrophy of the adenoid gland. Features of the larynx. Funnel-shaped cylindrical form in adults, funnel-shaped form in children. Narrow lumen, tender and pliable cartilage, relatively short. Mucous membrane is thin, delicate, rich in blood vessels. The glottis is narrow in children up to 7-6 years of age. Vocal cords are short, so voice in children different from adults, high voice. Features of the trachea the same with larynx, narrow lumen, water and can-like form, delicate mucous membrane, rich vascularization, weak development of the mucous glands. These features of the larynx and trachea can lead to stenosis of the trachea and the larynx, croup. We call them croup. Features of the bronchi. Cartilaginous, semicirculus, and soft. Elastic fibers are not sufficiently developed. By the time of birth, bronchial tree is formed and the number of branches does not change during life. Bifurcation in newborns is higher than in adults. Right bronchus is a direct continuation of the trachea and runs vertically. On this picture, you can see two large bronchi and the right bronchus, continuation of the trachea. So, foreign bodies easier pass to the right bronchus, and to the right lung. Mucous membrane is loose, well vascularized. In the bronchial mucosa, there are insufficiently developed mucosal glands, muscular and weak development of muscles and ciliary epithelium, incomplete myelination of the nerve vagus, and underdevelopment of the respiratory muscles leads to poor drainage function and obstructive syndrome in children. Features of the lungs in children. Individual parts of the lungs develop unevenly. In children of the first year of life, upper part of the left lung is underdeveloped. The upper and middle parts of the right lung have almost single dimensions. At 2 years of age, the ratios of individual parts correspond to adults. Anatomical structure of the lungs, you can see this picture. Terminal bronchi of the lungs in newborns do not end in alveoli but in sacs, from the edges of which new alveoli are formed. In newborns, the number of acinesis is 3 times less than in adults. Interstitial tissue in young children are not developed. The segmental structure of the lungs in children is the same as in adults. 10 segments in each lung. Breathing features in children. In newborns and infants, breathing is irregular. This is normal condition. Types of breathing. Diaphragmatic type of breathing prevails in newborns. In infants, thoracic type. From 6th age, thoracic type of breathing begins to prevail in girls, and abdominal type of breathing in boys. In newborns, especially in premature babies, there is apnea, respiratory arrest, which lasts 5-10 seconds, and instability of breathing rhythm, normal condition for premature babies. Complaints. If patients with respiratory tract diseases come, you should ask about next complaints. Cough, the most common complaint. Difficulties of nasal breathing. Pain in the chest. Disorders of the rhythm and depth of breathing. Dyspnea, sneezing. The presence of nasal discharge or sputum in the respiratory tract. External examination. You can check position of the children with respiratory tract diseases. Forced position, like orthopnea, in patient with the attack of bronchial asthma, obstructive bronchitis, and asthmatic bronchitis. Position on the affected side, you can observe in patient with lobular pneumonia and pleurisy. Discoloration of the skin and mucous membranes, like as perioral and periorbital cyanosis, you can observe in patients with acute inflammatory processes like pneumonia, bronchiolitis, and in patients with congenital anomalies. On this picture, you can see attack of the asthma and fourth position of girl with attack of asthma and girl with cough during attack of asthma. Attack of whooping cough in children. On this picture, you can see 2 babies with whooping cough, very severe prolonged cough. Systemic cyanosis in patient with congenital problems of the lung. Respiratory failure in infants with some features like as foam at the corners of the mouth, the breathing of the hunted bees, inflating the wings of the nose. Changes in the chest. Barrel-shaped chest, typical for bronchial asthma and emphysema of the lungs. Chicken chest, kill chest deformity, typical for patients with chronic pneumonia, but maybe kill chest deformity, congenital chest deformity. Unilateral depression, typical for chronic pneumonia and tuberculosis. Unilateral protrusion, typical for emphysema and pneumonia. Participation of axillary muscles, typical sign of respiratory failure. Lag in the act of breathing of one half, typical for pneumonia and pleurisy. Deformation of the bones. Pay attention on the first picture, baby with killed chest deformity. Next picture, baby with clubbing fingers and nails. Typical for severe chronic hypoxia. For assessment breathing rate and breathing in children, you should know about normal indicators. Normal breathing rate. In newborns, 40-60 per minute. 1 year old baby, 35 per minute. 5 years old, 25 per minute. And 8 years, 20 per minute. After 8 years old, like an adult, 16, 18 per minute. We can say this baby, this child with dyspnea, with shortness of breathing, if breathing rate in patient up to 2 months, more than 60 per minute, 2 to 12 months, more than 50 per minute, and more than 1 year old, more than 40 per minute. Types of dyspnea. 3 types of dyspnea: inspiratory, expiratory, and mixed. Inspiratory, difficulties of inhalation with obstruction of the upper part of the respiratory tract, typical for children with laryngitis, with croup, foreign body, tumors, congenital narrowing of the larynx, trachea, bronchi, and pharyngeal abscess. Expiratory type of dyspnea, difficulties of exhalation, typical for patient with an attack of bronchial asthma, asthmatic bronchitis, and bronchiolitis. And mixed dyspnea, typical for bronchiolitis, pneumonia, heart and vascular diseases, rickets, ascites, and flatulence. Inspiratory dyspnea. On this picture, you can see 2 babies, one baby with laryngitis and next baby with foreign body of the nasal cavity. Obstructive bronchitis, child, girl with cough. So if patient with dyspnea, this patient with respiratory failure. Signs of respiratory failure, 3 degrees. First, on mild degree of respiratory failure, dyspnea, shortness of breathing occurs only during physical exertion without the participation of axillary muscles, absent at rest. So, periaral cyanosis we have only after exertion. Respiratory failure of the moderate degree, 3rd degree. Dyspnea at rest, constant, with the participation of axillary muscles, retraction of the pliable places of the chest, even without exertion, at rest. Heart rate to breathing rate, 2 to 1. Normal condition, 4 to 1. Cyanosis, perioral, face, hands, permanent, does not disappear with 40-50% of oxygenation. Behavior, lethargy, adenomia, which is changed by short periods of excitation, decreased muscle tone. 3rd degree or severe degree of respiratory failure, dyspnea, respiratory rate more than 50% from normal, reduce blood pressure. Blood oxygen saturation is less than 70 with oxygenation. Hypoxia, hypercapnia, respiratory rate may be rare rate, bradycardia, severe metabolic acidosis, and hypoxic coma. Cough. Cough is the most common sign of respiratory tract diseases. Types of cough: dry cough and wet cough. Dry cough without sputum, wet cough with sputum. Dry paroxysmal cough with a whistling in the chest, typical for bronchial asthma. Barking cough for laryngitis. Cough with reprises, redness of the face and vomiting, typical for whooping cough. Sudden out of full health, sudden cough, typical for foreign body. On these pictures, you can see baby with foreign body in the respiratory tract. Wet cough. Wet cough in the morning, sputum in the morning, typical for sinusitis. Periodic wet cough, typical for lung abscesses. A strong host with a release of frothy sputum, typical for pulmonary edema. And cough during day, more in the morning, typical for pneumonia. On the next picture, you can see X-ray and girl with pulmonary edema. But pulmonary edema is not syndrome of the respiratory tract diseases. Maybe in patient with heart diseases, left ventricle failure. Objective examination of children with respiratory tract diseases: palpation, percussion, and auscultation. Palpation of the lungs. We can check three things: soreness, elasticity of the chest, and vocal tremor. Soreness, typical for dry pleurisy, myositis, neuritis, and traumatic injuries. Resistance of the chest or elasticity. Resistance increases with exudative pleurisy, decreases with rickets. Elasticity increases with rickets and decreases with exudative pleurisy. Vocal tremor increases with the lung tissue is compacted, for example, in patient with lobular pneumonia, and weakens when it is airy, in patient with emphysema. Percussion of the lungs. Comparative and topographically. Topographically, we can check borders of the lungs. Upper borders of the lungs we can check only after 10 years old. Lower borders of the lungs we check these borders by only 3 lines: a mid-clavicular line, axillary media, and scapulary on the right side. On the left side, only by 2 lines, axillary media and scapulary, due to heart on the left side. By mid-clavicular line, normal border 6 rib, axillary media 8 ribs, and scapulary line 10 ribs. Comparative percussion of the lungs. Normal sound we can check clear pulmonary sound in healthy children. Abnormal sounds of percussion sounds, dullness, and box sound. Dullness, we can check in patient with pneumonia, atelectasis, exudative pleurisy, and hydrothorax. Box sound or tympanitis in patient with bronchial asthma, obstructive bronchitis, and in patient with large cavities. Auscultation of lungs. Auscultation of lungs. Normal types of breathing, which we can check by auscultation, vesicular breathing, puerile breathing, and bronchial breathing. Vesicular breathing, we can listen to in children after 5-6 years old above the lungs. Puerile breathing, we can listen to in patient, in children up to 5-6 years old above the lungs. Bronchial breathing, we can listen in healthy children above the trachea, large bronchi, and larynx. Pathological types of auscultation, auscultatory sounds, hard breathing, and weakened vesicular breathing. Hard breathing, increase inhalation and exhalation, louder than even puerile breathing, typical for bronchitis. Weakened vesicular breathing, with limited air supply to the larynx, trachea, or bronchi. We can listen in patient with inspiratory dyspnea or in patient with pneumonia.